So as we said yesterday morning, and for those of you who weren't there, this is the first of two panels. This one looking back over the last 10 years, and the one this afternoon looking forward to the next 10 years. And what we've got for both of these panels is a group on stage who are going to give some thoughts about what they've seen happening over the last 10 years. We have Lynn, who is going to say some words on video because she is unable to be here today, unfortunately. And then we're going to open it up to all of you to give us some sense of, for you, what has been important over the last 10 years. And we're recording this session because we think it's a very important way to capture the progress that we've made since the last conference. And I don't know what that write-up looks like in the end, but we're gathering the material here in this session. So I'm going to ask each of the panelists to briefly introduce themselves so that you have some context for their remarks, and to give us some thoughts on what they've seen happening over the last 10 years. And Jools, because I took your microphone, I'll give it back to you to start.
Do I sing now?
No, that's at the end.
All right, okay. I've written myself some notes, so I actually stick to what I'm meant to be saying. So if anyone's seen any of my talks, you'll know I never stick to what I'm supposed to be saying. So looking back, I think for me, and I'll explain my perspective, I'm a patient and public involvement manager at a large medical school in the UK, up in the far north with wet Vancouver type weather. So I haven't even got socks on today. This is just like brilliant. You lot are all cold, I'm loving it. And I'm coming from a perspective of setting up a large group of people with lived experience that have got involved in medical education and now other programs. But it was originally medical education. So two things that have really struck me when I look back now. And I was here in 2005 as a teenager. Someone said yesterday, I love you for that. I wasn't. But I was like a rabbit in the headlights. I didn't have a clue what I was doing. It was really overwhelming. But actually, I quickly realized that being here, and Beth's already said it, and you've said it, Angela, it's being amongst your people. And when you are working in your institutes, in your hospitals, you are quite isolated, so you don't meet many people the same vision as yourself. So coming here and being with your own people was something I picked up pretty quickly and thought, this is a great friendly place to be. So I think there's been a slight culture shift. I'd say it's gone forward and backwards. But for me, since the past 10 years, we've had a culture shift in, if I've said to someone I'm working with, please, can you use the words work with rather than use patients? That will make a massive, massive difference. And people have said to me, it's just semantics, it's just words. Jools, stop banging that drum. It's way more than that. It absolutely is. If I ask to use you, it sets things up in a certain way. If I ask to work with you, it's a partnership. So I would say one of those real things that has come through is, and I wrote just a few words, from about to with is a shift. Use to work with is a great shift. Participants to partners is a positive shift. And I'd ask people to see the person first and the patient second, please, as human beings. So that's my first one, culture shift. The second one I put is strengthening numbers. I definitely feel that there's more of us doing this. We're a louder voice, we're a much more powerful voice, and it feels like we've more allies over the past decade. So that is a huge, huge positive for me.
Thanks, Jools. Would you like to pass the mic to Bram? Oh, he's got one.
We're going to do a duet.
Thanks, Angela. Hi, everybody. Good morning. My name is Marjadi. I'm from Western Sydney University. My day job is I'm an associate professor of community engaged learning, which means basically I need to make sure our curriculum reflects the voices of the community and the needs. I'm also an associate dean of engagement at my school. Reflecting on the last 10 years, I'm thinking of 6 major changes or developments, I should say. First one is COVID-19. Remember those years? Horrible, horrible years, but where our engagement with patients, with community, have never been the same since. Right? And that really threw a spanner in the works for many, many people. But at the same time, there are so many things that we learn that we can use to this day, because there are innovative ways that we can still maintain the connection despite all the masks and the spacesuit and all the rest of it. And number 2, which is a little bit more recent, is the development of generative AI. And how is that changing the landscape of how we engage with one another? Again, same story, lots of risks, but at the same time, lots and lots of opportunities as well. More locally in Australia, there have been a number of changes, development. One is the Australian Universities Accord, which is a major change, development in the tertiary education landscape in the country, where, among others, the universities are expected to be more mandated, actually, to be more porous to the community. To be more accessible, but at the same time also reaching out as well. And you can imagine that how much that can leverage on our engagement with the patients, with the community at large. There's Carnegie elective classification for community engagement has been coming to Australia, and we already rolled out the first round, and we're going to roll out the second round next year. Angela, you mentioned about, some of the reflections earlier mentioned about compensation, remuneration of patient engagement, everything. That was part of the Carnegie principles, so it's another lever that we can pull in Australia because of that. And the Australian Medical Council's new standard for accreditation, this is for Australia and New Zealand in 2023, has this new standard, which is mainly about community engagement, about patient engagement, and about health across the lifespan. So we have to teach our students, make them familiar with what the patient journey is. Another massive lever that we can pull to support our work. And the last one, probably not so much as positive, is about half Australian universities have been in the red since COVID. And unfortunately, if you think about the 3 missions of a university, we can't do without research because that brings in money. We can't do without teaching and learning. That's our core business. So what would go first when budget is tight, right? Community engagement is actually a cost center. Sometimes the bean counters would see it as a cost center, and so we have to survive under the new fiscal, financial situation. So in a nutshell, I see opportunities, I see challenges, I see the need to be agile, but I also see the need to be true to ourselves, to be true to our mission. And this conference always reminds me, looking back in 10 years, why are we doing all this? Some of the reflections mentioned, things have changed in the last 30 years. Isn't that what we're all here for? Isn't that why we're doing everything that we do? Thank you.
Thanks, Bram. Annie.
Bonjour à tous. Good morning, everyone. My name is Annie Descoteaux, and I'm a patient partner and a close caregiver at University of Montreal. And What really strikes me for the past 10 years is, when we look back, is how much has shifted from the inside of the university. And going on to what you said earlier, Jools, I came in 2014 when the Montreal model was just being born, and the main message of the Montreal model was to change the semantic, stop working about the patient, work with the patient. And that small shift in talking about the patient and talking with the patient, there's a long way, we've come a long way in the past 10 years with this small, just semantic way. And so we've, we were mostly, as patient partner, involved into pedagogical activities when it first started. And today, 10 years later, patient partners, we design, we lead, we take decisions in the pedagogical way, and we are involved in all the level of decision-making process. So there's a big shift that happened. It's not just a cosmetic one. It's I think we're changing the DNA of our institution right now, and Congress as this one today helps make it more solid actually, and make it impossible to go back to what it was before. I see another change as well that that we brought as patient partners is we've been contributors to the academic knowledge. So we're not just interviewees anymore. We're not just clinical cases and example anymore. We write scientific articles. We're co-authors and we're lead authors, and now we include clinician in our work. So we've shifted, we've come a long way. And also, well, I'm gonna stop there for now. Yeah.
Okay.
Yeah. I just need to gather my thought in English. I'm sorry.
Okay,
So,
I'll come back to you then.
Okay, thank you. Yeah.
Okay, James, would you like to play the video now? Thanks.
It took becoming a patient for me to see how much more I needed to learn about being a doctor. My name is Lynn Ashdown, and my life changed literally and figuratively in a heartbeat, from resident physician healthcare provider to waking up a full-time healthcare receiver in hospital with no notion of how I got there. Life as a doctor behind me, my intimate life as patient just beginning. A fall off a stool while studying in a coffee shop caused by a cardiac arrest secondary to a congenital heart arrhythmia was the culprit. A moderate traumatic brain injury, skull and cervical fractures, spinal cord injury, and numerous ensuing medical issues were collateral damage from the lifeless fall. That day, that coffee shop, altered every subsequent day of my life, dividing it sharply into life before and after illness. This includes the transformative learning that occurred for me, as my medical education taught me about disease and illness, but my patient experience is teaching me what it means to be ill. I'm honored to join everyone today to reflect on progress made over the last 10 years. While I did train in medicine, I was never able to return to clinical practice, and I am wholeheartedly a patient partner. In my life before illness, I was already interested in medical education and had already started my master's in that. While it took many years post-injuries to resume this master's, I was able to successfully complete this in 2022, and my dissertation focused on the role of patient partnership in medical education. My literature search for this dissertation took place between 2019 and 2021. While literature did exist, and the consensus statement from this conference in 2015 formed a large component of my argument, the research for the most part was quite minimal, with small amounts of high-quality studies or systematic reviews. In the last 4 years, however, I have noticed an explosion of literature on the role of patients in health professional education. Seeing this increase in data over the last decade signals what I believe to be a turning point, that patient involvement in healthcare professional education is here to stay. Another change I have witnessed over the last decade is the number of learners seeking out the lived expertise of patients. 10 years ago, I was deeply entrenched in learning about patienthood myself, but not that long before then, I was still a learner in medicine myself. When I was a learner, while we thoroughly enjoyed hearing from patients, it was not a regular occurrence, nor was it something we sought out if the curriculum didn't include it. However, I have seen this new cohort of learners who understand the power of patient expertise and seek out this learning even if it is not included in their curriculum. The number of learners starting special interest groups, taking extra courses, engaging in discussions with patients, and asking for change from their institution is beautiful to see. Again, this represents what I believe to be a watershed moment. And lastly, the role I have been thrilled to serve in over the last while is Patient Partner Lead Advisor to the Association of Faculties of Medicine of Canada, or AFMC. In 2023, AFMC hosted the inaugural International Congress on Academic Medicine, also known as ICAM. ICAM 2023 was the first academic conference to engage a patient partner in the co-creation of the medical education content and to involve patient partners in the development and presentation of the plenaries. In addition, it was the first academic medicine conference to achieve Patients Included status, which is a charter for conferences first established 10 years ago as a way for continuing professional development organizers to demonstrate their commitment to patient and public involvement in health professional education. At subsequent ICAM meetings, we have continued to maintain Patients Included status, introduced a patient partner research abstract, and expanded networking opportunities for patients such as the luncheon, an event attended by patient partners, clinicians, educators, administrators, and researchers. This represents the true essence of partnership, with all stakeholders coming together to collaborate. I have since seen other conferences adopt this approach at their conferences and professional development events. Feedback from ICAM has been that meaningfully involving patients has enhanced the learning of all attendees, legitimized the presence of patients in healthcare professional education, and dispelled myths that existed about whether patients can enhance healthcare professional education. With AFMC continuing to commit to including patients at ICAM and expanding each year, and other educational events following suit, this is another area in which I believe a turning point has occurred and will only continue to grow from here. I look forward to hearing about everyone else's reflections about changes that have occurred over the last 10 years.
Thank you. Annie, have you found
Yeah.
what else you wanted to say?
Thank you. I've gathered my thoughts. I just wanted to say one more changes that we've noticed in the past 10 years is 10 years ago, students were not so receptive at our presence around the table. They were questioning why do we have patients around the table, and they quickly, I would say, fell in love with the process. But 10 years later, without even asking, as a co-director of the Patient Partnership Office, we have students that come around, they just pass by, knock at the door, and say, we just want to say hello. I had a question. Do you think I could speak with a patient? So the shift of students coming to us, not because they have to, is because they really want to understand, make sense of their journey as a student, their own trajectory. They want to make sense of the complexity they're going to be confronted to. They want to make sense of the ambiguity and all these variables that they have to deal with. So that was a shift that I thought was really interesting, is that they are now searching for this relationship with patient partners within the university.
Thank you, and that fits with the comment that Lynn made about the change of students seeking out these experiences. Before I open it up, any further thoughts from you? Okay. Okay, folks, so it's your turn to provide us with some of your reflections on what's been happening in your world over the last 10 years. There are two microphones, one there and one there. So, anybody would like to offer some reflections? Don't be shy. Oh, and if you can say who you are so that we know who you are and where you're from.
Hi, my name's Connie. I'm from British Columbia Institute of Technology, so just down the road. Something that I've noticed, because I'm new I'm a faculty member, and I'm new to this process of working with patient partners. And so what I've noticed is there is a community out there, and so I have felt so well supported. Just speaking to everybody, so thank you so much. The UBC folks have been phenomenal, but I have reached out to the University of Montreal, and so I just love this open dialogue and the fact that we have, this group, whereas, when you're starting any initiative, sometimes you're lost and you feel alone, and I didn't feel alone in the process, so thank you.
Thank you.
Thank you for that comment. That's reminded me of something that we've been doing in the UK. You do feel isolated and you feel like everything is a struggle, but actually reaching out to other people within your country, within your region, within your area, you're absolutely right. You think, I can go back and do this. I've recharged my batteries. I've had a chat with someone who just gets what I'm talking about, and I don't have to keep explaining it. So I think we've benefited in the UK whenever our batteries have run down. We've got together and we've had a good yakka and filled our battery energy back up. So it's a really great point.
Okay, come along. Some of you must notice something that's happened. Yes, Jools is going to sing, so so thank you, Vikram. You've got a nice new shirt on today.
Thank you. My name is Vikram, and what I've noticed is that obviously, I'm sure many people in the room are familiar with the different spectrum of engagement. And I found that we have not moved the needle to where it needs to be, because I find that all the different health organizations and everybody else have been focusing on the consulting but not moving to the collaboration or the other one. I forget what the first one is, but I don't know if that is a consensus or am I just imagining things. Because I've obviously been in the health system for a very long time, just trying to see if that needle needs to move, if we're going to move it much quicker or sooner rather than waiting for it to happen, I guess. Or if it, I don't know what I'm trying to say, but I'm just trying to, yeah.
Yeah, I think you're right, Vikram. I mean, we're still a long way to go in terms of moving from consulting through to partnership. But I think that what I've noticed for this conference, which was different from the last conference, is a lot more presentations that have the word co-creation in the title. Co-development, co-creation, and people really seriously thinking about what that means to work together, because it's not easy and it's new for all of us. So I think that I think the needle is moving, and it's slow work, and I think that's okay because it's hard work. And if it was easy, we would have done it by now. But I think it is definitely moving, and we have to be patient, because if it's going to really get embedded and deeply thought about, I think it does take time. Yep.
I think that you were...
Oh, right, we've got a lineup. Okay.
You have a lineup
Okay,
here.
Jennifer.
Hi, yeah, my name is Jennifer Daly-Sear.
Jennifer.
Yes, Jennifer Daly-Sear from Ottawa. And I just wanted to share something that has recently come about. One of the organizations that I do advocacy work with, I am a patient partner, person with lived experience of pain, and it's a chronic pain network. And they've recently launched something called Pain Connect. So being that it's a research network, a patient-oriented research network, they've launched Pain Connect in order to sort of match, if you will, match patients with researchers and trainees. So it's a way to facilitate that dialogue, and it was sort of an in-demand thing by the researchers and the patients themselves. So I wanted to share that. It's called Patient Connect. Yeah.
Thank you.
Example.
There's a theme about connection here, I can tell. Okay, thanks.
Hi, I'm Brett. I'm from the Australian National University. I don't work from a lived experience perspective, but all my work is about lived experience-led education. And I guess riffing off the points that were just made before about there's a lot more that's happening. And I made a note, Jools, you said there's a lot more, I'm just trying to read my notes from my laptop from afar, but Jools, you said that we're moving a lot more towards talking about partnership over participants. I think that's what my screen says. And I think that's great, but I'm also seeing in that a lot more tokenism that's embedded. I think, it's great to talk about partnerships and doing things that are but if you're not actually partnering and you're not actually looking at how to address power, then it becomes worse. Like, it's almost a lie to say, oh yeah, we're partnering when we've just done a bit of co-design or we've done a little bit of consulting. And those things aren't bad in and of themselves. Some people are trying to rush up that participatory ladder. And I guess what I want to see is more honesty in where we are actually at, rather than trying to say, oh yeah, we're doing everything whatever. Not to bring it down, but it's definitely a feeling I've been having over the last day or so.
I totally agree with you, and thank you. What I would say is different from me as a patient and a carer in the UK, and I also head up a large group, is that if you look at it from the other perspective, right? I work in a university, I know what researchers can be like and the impact they can have negatively, and academics and clinicians and everything else. 24 years, I've had, you dream, make it up, I've done it, I've been through it, right, okay? But what's shifted for me is people like me that are non-academic or non-clinical have found their kahunas, and we can now call it out. So I think that's where the shift is. Maybe other people's behaviour hasn't moved as far as we'd like it to, and it should do. And if we had governing bodies to enforce that all over the world, they would have to do it. But people like me will sit at a table and go, hang on a minute, you've just asked me or my group to get involved in a partnership. Basically what you're doing is consultancy. You've already done it. You're just asking me to put my name to it, to tick that damn box, and I'm not doing it. And they're like, oh, I've been found out. I'm like, if you genuinely want to work with us, let's go back to the beginning. And I think that power and that confidence to say no, where we all used to just go tug our forelock and go, yes, sir, anything to be involved, sir. No more. I think that's where we've shifted. And because there's more of us and we're allowed a voice, even if you stand up and go, I'm gonna hold you to account for that, there's so many people behind you now, whereas I did it years ago and I used to go, no, hang on a minute, we are not having it. And I'd look behind and everyone had gone. It's like, oh, it's the mouthy one again. So I think that's where the shift has come, and we need to push it from our perspective. Until governing bodies, Australia seems to be doing it, the UK isn't. So we hold people to account over co-production and partnership or tokenism.
Can I just quickly add, co-design has been such a buzzword, and unfortunately not all co-designs are equally created, and unfortunately I have seen a number of cases where it stops at the design, and then let's design it together, and then leave the execution to us, okay, the academics. Leave the assessment to us. Leave the evaluation to us. You've done so nicely in designing it. Let's leave it at that, right? Let the grown-ups do it, exactly, right? And this is something that I would like to challenge all of us, right? At Western Sydney University School of Medicine, for example, when we send our students out in the community, that's the way we do the patient contact, is through the community. 50% of the mark comes from the community. If the community decides that they are not safe, that are not listening, the student cannot pass the subject. That's given power to the community. We academics, we only do 50% of the marks, right? And if the community is not happy with them, they're not going to pass, right? So that's something, and then we co-evaluate it. Is it working for you? Do you have any suggestion how we can improve the interaction? Oh, our students tend to be just fly on the wall, not engaging. Okay, this is not what we want to do. Okay, let's figure out how can we do this? Should we put it into the assessment? How can we do this together? Now, for me, that is, that equal sort of footing partnership is like that. And just one tiny little thing from Carnegie is mutuality and reciprocity is a principle. We all involved, many of my community partners said, why are you doing that? When I asked them, why are you doing this unpaid? They say, well, we got vested interest. We want your students to become better doctors because they're going to serve us. Yeah, so my next question is, why wait? Give me a challenge so that my students can do something for you now while they are still students. It's all well and good for them to become better doctors in the future, but why wait? There's so many things my students can do for you now. Give us the challenge, we'll do it with you. Thank you.
Thank you. Yeah. Yeah, you can clap, it's fine. Okay, Darren.
Darren Lauscher, Vancouver, patient, but not just an educator, but a researcher. I straddle both worlds. And so I see linkage between those both worlds. And the reality is research takes 10, 15 years to get into a textbook. I, as a patient, can bring it into that classroom, bring it alive. Today, with research that was published yesterday, because I was also on that team. So we have an insider perspective that can be beneficial in the bigger picture. Where I've seen the shift since 2015 is the buy-in is getting greater, you're understanding, the choir is in the room, we are singing well. Yes, there's a few off keys, but it is our bureaucracies, the institutes that we work within, that keep throwing up barriers. But we've always done it this way. Oh, yeah, okay, we're gonna sidestep and create another barrier because you've broken that one down. That's where I see some of the problems. I just got an email yesterday from UBC, who I do a lot of work, and the bureaucracy, you shall not do this any longer, you must do this, this, and this. And I'm like, oh. So how are we going to bring those patients that we've been giving an honoraria to, and now you've created another hurdle. Shame on the institutions. So that is where I see some of the big issues are, is our institutes need to change. And we know change can happen because COVID happened. We changed.
Yeah, thanks, Ben. Okay, over to this side.
Good morning. My name's Andrew Johnson. I work at Center for Addiction and Mental Health. Highlights over the last 10 years. Maybe I'll start with just the fact that I had the privilege of coming to this conference 10 years ago. And what that did for me and for a lot of the people that I work with was it gave us courage and it gave us encouragement. We knew that there was a community. We knew that there was rigor, people thinking hard about centering the voices and experiences of people with lived and living experience. So that was super important. And since then, we've been able to deal with some of the adversity that we hear here, tokenism, really inflexible bureaucracies, all the stuff that we get to name. On the other hand, I love the comment that was made this morning that a lot of this work is changing the DNA of the institutions that we're working in. I really believe that. I can get really undone by finance people or HR people who just don't really get what it is that we're doing. And I just saw lots of reactions, so we all know what we're talking about. But on the other hand, you know, I have a role where I'm being invited to do this work. They pay me real money to go and do this work, and that is incredible. Like, I'm so grateful for it, but the move that we're watching, that wouldn't have happened without all of the people doing this work around, and we don't have to explain. We might not do co-creation or co-design like perfectly each time out, but we don't have to explain what it is, or at least not nearly as often as we used to. And as we continue to do it and refine it and then reflect on what did go well and didn't go well, maybe we'll come to some standards. Maybe we'll think about what actually passes muster. I mean, that's kind of where we're going here, like moving past just superficial forms of engagement or centering of voices to deeper, ever deeper. But as we hear those voices, they continue to resound and echo, and they're not going to go away. So that's, I'm seeing the challenges, but I guess I'm trying to inject a note of optimism, at least from where I sit.
Thank you, Andrew. And I like that. We're not going away. Over here, thanks.
I'm not going to move the microphone. You did that like an absolute rock star, and I don't know how to do that. So, but yeah, hopefully you can hear me. So, my name's Steph, and I work in the UK. And just building on a couple of points that have been said, in the UK, and I do believe in other places too, there's more mandating for public involvement. So, for example, the National Institute for Health Research in the UK is saying that you have to have public involvement now in order to apply for any funding. And it's coming into policy as well, which creates huge opportunity. You know, there's funding options there. We have a seat at the table, like Jools said. But what I'm mindful of is that we're not at every table, and we're looking at structurally ingrained views. And there is the risk with this type of activity that if it is done without the thought or without the wealth of expertise in this room, it can damage trust and it can crystallize that inequity. And terminology is used incorrectly at the moment, although it is used more. There is still tokenism, and it could crystallize that more. So my feeling with that, to give a positive spin, is that there's a huge amount of expertise here, and there's development of guidelines that we're going to be working on again tomorrow. My feeling is that amplifying that can really prevent that damage. Being loud, pooling together, and positioning this group as experts in the field can be really beneficial. We need researchers, policymakers to be coming to us, because we're not at every table, but I do think the door is ajar. I do think they may hear us out at this point. And I think actually across the next 10 years, if we can really pull together, really work hard to amplify the guidelines that are developed, we have real potential to gain some momentum. So there's some funding, there's some options that we might be able to tap into, but also we can prevent the inevitable harm that comes from those really challenging conversations we've been in. If we're not at the table, they happen. That engagement happens and the damage occurs. So that would be my feeling. Thank you.
Thank you. Mike.
As you were asking what's happened in the last 10 years, I was thinking back to my very first patient.
Would you just say who you are?
Oh, my name is Mike Lang. I'm from Calgary, and started as a patient advisor 16 years ago. And that's what I was sort of reflecting on when you asked that question. And so I was thinking back to that. I was diagnosed with cancer at 25. Apparently, I was a pretty opinionated 25-year-old because the head of the cancer center asked me, Mike, do you want to be a patient advisor? And I didn't know what that was, and I don't think he knew either. And so I was thinking my very first patient advisory experience, he walked me into the room, and he said, hey, this is Mike, he's had cancer, he's going to be your patient advisor. He walked out, and it was me and 10 oncologists just sitting in this conference room. We all sort of looked at each other like, what are we supposed to do? And we had no idea. And I think the biggest change that I've seen over the past, I guess maybe 16 years, is sort of, I would say, the level of investment in patient and family partners. And, you know, that's literally was my introduction. It just put me in a room. I had no idea what I was doing there, what I was supposed to be doing. You know, neither did they. And we figured it out over time, and obviously, you know, here I am, you know, 16 years later, but I had to sort of do it the hard way. I went back to school, did my master's and PhD to sort of understand what is this even supposed to be and how are patients and families supposed to be embedded. And when I look around the room, I read the posters, go to the presentations, I think the biggest change for me is the level of investment in patient and family partners that occurs now is just so different than 16 years ago, where they would just put me in a room with people and there was no training, there was no guidance, there was no sort of level of understanding of what the relationship was. And to me, that's pretty incredible to see so many patient partners here and the level of investment that they've received from the different institutions that they're advising, I think is incredible. And so I think, you know, that maybe that's just a bit of an encouragement, you know, to continue to do that, because you can see there's patients here who are running entire programs at universities and things like that that started out as a patient advisor, and I think it's incredible to see the level of investment even here in this room. It's amazing. So that's my reflections on 10 years. So
Yeah, thank you. And it reminds me, Darren and I chair a patient and community advisory group at committee at UBC, and for the first, what would it be, 3 years, nobody knew what to do with us. We were the ones that, you know, were kind of saying, hey, can we be useful? And then eventually we start getting people coming to us and wanting, you know, being proactive. But it took a while. They're like, what do we do with these people? And that shift's happened. Yes.
I'm Virginia McIntyre from Nova Scotia. I've been doing this for probably about 7, 8 years, and I am seeing changes. I agree there's times, you know, you're the last one coming in, and they want you to sign off because you're patient partner, and then not want me because, again, was probably maybe a little mouthy, and said no. But I'm seeing changes. I received a grant from SPORE's Strategy for Patient-Oriented Research. I got the funding. I led the grant, and the professor I was matched with out of Newfoundland, I mean, our RAs were having a problem knowing that I was part of the leadership team, but she changed the tone. We're becoming leaders, and that is what's really nice. And what Jennifer and I are doing with the Action on Pain podcast, we're amplifying the patient's voice in Canada, but CPN, Chronic Pain Network, are funding us, but they're letting us take the lead. We're doing what we feel is necessary with this. So I see that change in which I never seen that 7 or 8 years ago. They're letting us, they're having faith, a little more faith, and not everybody, we have ways to go. But we are becoming leaders.
Thank you. Well,
yeah, really resonating with that. What I would say, especially for those who are new and those who are, you know, like we all see the bureaucracy of the university get in the way and all this kind of thing. You know, my advice is make a noise, make lots of noises, be leaders, absolutely, right? Because this is something, if we truly believe that this is something worthwhile, this is something important, right? But the only way we can break through all those barriers, all the red tapes and everything like that, is that if we are known to be leaders, right? If we are doing good things and we got acknowledgement. Now, in Australia, there is this thing called tall poppy. If somebody starts talking about their achievement, other people will knock them down, okay? That's just an Australian thing, right? But I found over the years that being really good at what you do really opens up doors, because then people start listening to you. People start believing in you, and what you do suddenly becomes more interesting, more attractive to people because they can see what you have achieved, like that. I remember back in the years, I was a senior lecturer for 10 years before, 7 years? Yeah, 7 years before, well, actually, no. 10 years before I got promoted as an associate professor. And back then, I was so happy being a senior lecturer, so very happy with that. Why would I want to go any further? More work to do, right? But one of my mentors sort of said to me, you know, you need to show people that community engagement work matters. And at that stage, she said to me, I would love to see that one day somebody is getting promoted academically because of their community engagement work. And I told her, I will strive to be the first one in the university for that. I'll put my hand up for that, you know. And, you know, a few years later, I did it, right? And it suddenly becomes, you know, like that acknowledgement that you are good at what you do, and more importantly, what you do actually matters, right? That is incredibly important. Just a few weeks ago, a couple of months ago, the medical deans of Australia and New Zealand emailed me. Basically, I spoke with them about community engagement, the importance of it, and how rare it is to find one another, how difficult it is to collaborate, and everything like that. And then they talked about it in the executive, and then they emailed me, thank you for approaching us with that. We decided that we're going to establish a community of practice across medical deans, Australia and New Zealand, and we want you to chair that. And I was thinking, wow, okay, I need more work like a hole in the head, but that's leadership. That's kind of like an opportunity to bring this issue all the way up. And within a very short time, I got 8 other colleagues that I'm bringing with me, and suddenly we realized that, hey, now we can do something big now, because now we found one another, and we have this vehicle that was given to us because people start listening to what we do. So my suggestion is, you know, my reflection of that is that, you know, like, make noises, make lots of noises, show people that what we do, it matters.
Thanks, Bram.
Can I just do a quick one before I see? You made me think about my first committee meeting. And you were saying 3 years it took. I remember my first committee meeting, and I walked into a room. I'd been invited. I found the room. I was almost late. And there was a big wooden table, and there was lots of pinstripe dinosaurs there, you know, elderly, white, greying men in pinstripe, very expensive suits. And I came in, and I went, oh, hi, and went to take a seat, and they went, just bring the catering in, and we'll... If anyone's heard me talk, you know I've got a really big mouth. I can't even say it was noise. You couldn't repeat what I said. But I met them in a committee meeting a number of years later, and that man could not look me in the face. But I made him look me in the face, and I offered him a cup of tea.
Bonnie.
Hi, Bonnie Swatsky, Associate Professor in Orthopedics here at UBC, and also been involved with the Health Mentors for years with Angela at the beginning. You know, early on in my career, as someone who is disabled in orthopedics, the last thing you need to do is show your weakness. And so I never talked anything about my own experience as a patient, right? Because I had to put on my objective lens and my objective hat and do everything without ever talking about it. But after years and years of having, now including patient's voice, I'm like, oh, wait a minute, I have my own voice too? So I can actually interject into that, and it's actually opened up opportunities for patients to also engage more with me and tell me their stories, and actually now start encouraging our faculty. And so I think, you know, yes, I'm wearing 2 hats. Sometimes I'm wearing a patient's hat. Sometimes it's an orthopedic patient hat. Sometimes it's a cancer patient hat. It's whatever patient hat you want to put on. And then I've also got my objective, supposedly. But we have more narrative approach to research. We have more narrative approach to education. And I think that has played a huge role in how we're shifting. And so just remind you, you're all patients in this room, unless you're a very exceptional person. And so it's okay to reflect back on your own patient experience and think about how that is impacting your education approach.
Thanks, Bonnie. And would someone take the microphone and put it back so that Sasha can make a comment? Thank you. We'll have another couple of comments.
Hi, I'm Sasha Agrawal from Toronto. I was here 10 years ago also, and have really admired and appreciated many of the things that have been spoken about today. And one thing I would want to highlight as both a highlight and a challenge, and I'll just speak personally. 10 years ago when we were doing this work, when I was doing this work, I wasn't thinking enough about intersectionality. It was enough to be fighting to get patients at the table. I wasn't thinking about which patients, which communities, whose stories. And I think the field has evolved. We've had Black Lives Matters, we've had the Truth and Reconciliation process, we've had lots of things unfold in those 10 years. And I still think we have a lot to do, because I think if we're going to talk about inclusion, which is the value that brings us to this room, I think we cannot stop at inclusion of patients. We need to think about who gets to those tables, because the same social forces that order all of our lives in every space, which make it harder for some folks to access power, operate alive and well and just as easily in these spaces too. So I would invite us to be thinking about every engagement, every opportunity. We have to apply that lens so that we don't leave people out in this process.
Yeah, thank you very much, Sasha. And I think, I think your comment is something that kind of links the last 10 years to the next 10 years. And I think that some of these themes that we've talked about this morning will pick up again in the afternoon, because it's a continuum. We're not sort of having a hard line between the last 10 and the next 10. So I'm sure some of those issues that you've all raised that we'll be talking about this afternoon. So we've got time for 2 more comments, and then we'll pick it up again this afternoon. Yeah, I have it.
Thank you very much. I'm Hassan Abdullah. I am Associate Professor of Medical Education at the University of Limerick in Ireland, but originally from Sudan. I think the noise mentioned by Braham needs to reach the accreditation bodies, because mentioning this issue in one of the accreditation standards will be like changing all the game. And I remember that when we started the social accountability, things started in 1995, and lots of years went until 2013, when the WFME mentioned it in one standard, and everybody started to talk about, let us be social accountable, and social accountability by default, including patient voice. But to have this in the accreditation standards, I think this will change the game. I hope this will be either in the discussion tomorrow or maybe in the afternoon. But just people to know that the accreditation standards will change everything. Thank you.
Yeah, thanks. And I think that's a point that we'll want to pick up on for sure. And you get the last word, Ben.
Does this move up, or do I lean over?
Yeah.
You don't need to be super close.
Oh.
Stand up, they'll hear you.
Okay, can you hear me, I guess?
Well, you can take it out the stand. Take it out the yeah, there
rock
you
star.
go.
Okay, sure.
You're a rock. You're a rock. Be a rock star.
You can tell I haven't used these before. Okay. Complicated technology. I'll be brief. My name's Ben. I'm from Nova Scotia, and I wear 2 different hats. While my PhD was in history, its disruption by epilepsy surgery led me to work in a gratifying role as a research coordinator in a neuroscience department based on my lived experience. And I feel that, as Lynn touched on in her talk, the gradual opening of medical conferences to patients and caregivers, starting with the first ICAM in Quebec, marked a key role in recruiting patients to academic health care. And this has evolved over time in the, 3 short years since then. My favorite part of ICAM was always interrogating scientists over their posters from a patient's perspective. And it's been very encouraging to me that in a short time, they've become more and more comfortable speaking with patients for their perspective, and clearly find it valuable and interesting, because these are not questions you can ask in a 15-minute doctor's appointment or a review of forthcoming surgery. And this Patient's Voice Conference is the most outstanding event I've attended so far, because it's turned things on its head, where there are so many posters and presentations from patients that it's a very encouraging path, and I look forward to it continuing to grow in the future.
Thank you. Okay, so it's time for coffee, and I know that you're getting restless. So we'll continue this conversation, and Jools is going to sing, so you'll be out the door like a flash.
I obviously haven't got to sing, but I will be out in the foyer serving you hot drinks in a minute.
Thank you.